Leslie Colip is a board-certified endocrinologist and an internal medicine physician. She earned her medical degree at Temple School of Medicine and followed that by additional training at the University of New Mexico. At Lehigh Valley Health Network, she's been instrumental in developing and launching the Gender Affirming Health Program at Comprehensive Medical Services, where she serves many transgender patients, and we're very happy to be able to refer them to her. Prior to that, Dr. Colip was a founder and medical director of the very first transgender health clinic in the state of New Mexico. So she is an ally, and I'm proud to call her my friend. So welcome, Dr. Leslie Colip.
Thank you, Corinne. I'm so excited to be here. This is a talk I put together special for tonight, and I added a lot of the nuances that I talk about in my clinic, and I hope it's helpful for all of you. And if you have questions, please interrupt or through the chat, and we'll get started. Thanks so much for having me here tonight. So, talking about masculinizing hormone therapy, as you all know. Let me see how this works. There we go. I just want to have a quick trigger warning. I use, as most physicians or providers doing an informed consent process, anatomical terms in some of these slides. That can be less than affirming, I realize, for patients, but realize it's part of the initial process for clarity. I also have no reported conflicts of interest I wanted to add as well. So since this is a talk about masculinizing hormone therapy, I wanted to bypass all the terminology discussion. I'm going to talk a little bit about gender dysphoria, but how do you get to hormones? How do you get to an office to get hormone therapy prescribed? In the past, there was a traditional way to do this, and there's some providers in the Lehigh Valley that still go through this type of organization. And essentially, it means you go to a therapist, you have several sessions with the therapist, and they diagnose you with gender dysphoria, write a letter of recommendation to a medical provider to start hormone therapy. And then the medical provider can really go quickly through their process and just prescribe, and then you're out the door. Unfortunately, there's not a lot of gender therapy specialists in most places throughout the country. So this is really thought to be a gatekeeping type of model. So more and more, what WPATH is teaching and some of the other specialty centers throughout the country and throughout the world is the informed consent model, which is what we follow in my clinic. And what that means is that any healthcare provider in various specialties, OBGYN, primary care, endocrinology, urology, we can, if we have the experience and the knowledge of the informed consent process, diagnose gender dysphoria in our clinic visit, during the initial visit, hopefully, and then provide hormone therapy care. So you don't need to see a therapist before. Sometimes you see a therapist while we're going through the process if there's behavioral health issues that are not stabilized, or there are issues in the gender journey that need to really be discussed more, but it's not a hoop to jump through. In order to get through the informed consent model, what it really means is that we go through the risks and benefits of any therapy and any alternatives that might better suit you as the patient. And the hope is that this will open up care so that you can get hormone therapy through, ideally, your primary care provider in the future. So gender dysphoria, I won't dwell on it. You've seen, I'm sure, slides before that have described it, but I just wanted to talk about why we even have to have gender dysphoria in our conversation. So a lot of people that are, that are trans and non-binary actually don't have a huge dysphoria component, especially years after therapy. The problem is that we have to assign a diagnosis to the issue so that we can bill for labs, we can bill for other interventions like surgery. So this is still used as an umbrella term even years after treatment, and it's really a misnomer in a lot of cases. The billing codes are very, very antiquated, and they're going to be updated next year. And one of the reasons I'm showing this is because it is offensive to a lot of us, but it is the terminology currently for the way we code for medical visits. So you might see this, for instance, on your labs that you get, this terminology that I don't like to say out loud. But this is this is how antiquated our models are in the medical system right now. So next year, I'm sure that a lot of this is, almost all of this is going to be thrown out the window. A good clinic, a good provider is going to be following one of the specialty society guidelines. I follow the Endo Society guidelines and the WPATH guidelines. There's also the UCSF Center of Excellence for Transgender Health, which is awesome for anybody that wants to look up questions pertaining to transition. It's really readable for people at, all different levels of education and medicine. So I think anyone could really get a lot of information out of that, even if they don't have a background in providing medical care. So what we're talking about in terms of masculinizing therapy is really twofold. We're trying to suppress the endogenous production of sex steroids in the body and then replace it with a masculinizing sex steroid. Every human body has, in large part, I'm not going to say there are different conditions that are outside of the box, intersex conditions, things like that. But in most human bodies, there is a balance of testosterone, progesterones, and estrogens, and they're varied throughout person to person. So in our approach, we are suppressing the endogenous production, that means the internal production of the hormone estrogen, and replacing it with testosterone. Per the guidelines, this happens at age 16. Before that, some people are on puberty blockers. I don't really talk a lot about peds in this lecture, but in the guidelines, I don't necessarily agree with it, but age 16 is when testosterone therapy is recommended to be initiated. A lot of us push that age down because most people go through puberty before the age of 16. So, but that's what a lot of people who are by the book will start therapy at age 16. We try to replicate a puberty, essentially, a second puberty in people that are starting on hormone therapy for the first time. And really, it's a puberty over the course of 6 months. We start with a lower dose of testosterone and then titrate up. Usually, I get patients to their goal testosterone level in about 6 months. And the goal testosterone level is arranged based on cis male goals. So this hopefully will give the body time to adapt to the very potent hormone that is testosterone.
So speaking of potent hormones, we have a question.
Yes.
And you were talking about insurance codes. So this might be a good place to talk about it. So somebody said their insurance has them listed properly as a male, but the issue is that because they get such a high dose of testosterone, that the insurance is often denying their coverage, even when they have a prior authorization. And then, that requires lots of phone calls and, fighting up and things like that. So any suggestions that you can offer other than like making really good friends with the clerical staff at the practice?
My experience has been that the insurance company is following cis guidelines for hypogonadism, meaning low testosterone levels in cis men. So when they see normal testosterone levels, they think you don't need testosterone, even though you're on testosterone. So what they want to see is a low testosterone. That's how testosterone is prescribed to cis men that are hypogonadal or have low testosterone. So it's not applicable. So what the provider needs to do is talk to the physician at the insurance company and do a peer-to-peer and say, you're not following the right guidelines here. You have to follow the WPATH or Endo Society guidelines here. They're not really thinking this through very much.
And I know that, with things like, trans masculine people, generally they need to get pap smears and they have other reproductive health things that they need taken care of. And I know that myself as a trans woman, my PSA tests get denied, with regularity and things like that for my prostate. And so is there things that we should be doing as a patient to remind the doctor or the provider that they, need to make an extra note in the chart or something like that to try to get that? Maybe we can head it off at the pass a little bit.
It's tricky, because I think a lot of us are really conscious about using an affirmed gender very overtly in the chart. And gender dysphoria is often placed into the problem list, but sometimes it's removed after so many years. There is, at Lehigh Valley, we have an anatomical inventory where we update what anatomy you have currently. If you have any surgical interventions, then we take that into account. But the anatomy you were born with and the anatomy that you possibly might develop on hormone therapy, and then surgically what is changed. In terms of insurance coverage, it is usually just a conversation if it needs to happen at all. But I think it's really important to preserve privacy in the medical record. And at a certain point, it doesn't, after years of therapy, you don't need to have your first problem on your list be gender dysphoria anymore. So it is tricky, but I think with the appropriate conversation, it can be sorted out.
Mm-hmm. So maybe even just, having a conversation when we're in on the doctor's visit, saying like, hey, as a reminder, you're probably going to need to have a one-off conversation with the provider or with the insurance doctor. Yeah.
Excellent.
Right. Perfect. Thanks.
Okay. So managing expectations on testosterone, as with really a lot of different aesthetic changes that take place in the body. It's really genetics. There's a lot of genetics to how you're going to respond to hormone therapy. And so that's dependent on a lot of things in terms of testosterone changes. The age that you initiate therapy, the body habitus you have, your BMI, if you're carrying a large amount of fat on your body, that is a estrogenizing organ essentially. So you might have less of a masculinization change in terms of your body fat distribution, for instance, your ethnicity, the amount of facial hair and body hair that other men in the family have, androgen mediated scalp hair loss. So in other words, male pattern baldness. All of that's genetic. And it doesn't follow on the mom's side, all of that, that's not true. It's really just crapshoot, essentially. Hard to predict. Then there's environmental factors, diet and exercise, really important for masculinization outcomes. And I'm going to talk about that in a second, a little bit more. So all you need for masculinizing hormone therapy in a simplified way is testosterone monotherapy. It's such a potent hormone that it overrides the effects of estrogen very quickly and produces, relatively speaking, rapid physical changes. I discussed this earlier, that everybody has, in most bodies, a balance between estrogen, testosterone, and progesterone. And you either get from the gonads the production of testosterone and estrogen, or the adrenal glands are also producers of those hormones, usually to lesser degree. So keep that in mind, that if things seem off hormone-wise on your labs, that this is a little more complicated and might need some further discussion. This is a really complicated slide. What I really want to show here is that testosterone is metabolized in a lot of different ways, and it's pertinent in terms of some of the therapeutics we choose to deal with the side effects from testosterone therapy. So a large part of testosterone is inactivated when it comes into the body. This is people that have a rapid metabolism of testosterone. They can basically just eat it up and get rid of it, and none of it's really activated or used. And that can be different from person to person, which is why different people need different doses of testosterone, even if they have the same weight and they're, everything else is the same between two people. They might be on completely different doses because some people metabolize faster than others. Some of the testosterone is converted to a very potent type of testosterone called DHT. And that is a testosterone that's often abused in the bodybuilding world. And can be blocked with some of our testosterone blockers to preserve hair, scalp hair. So I'm going to talk about that in a second. So about 5 to 10% of testosterone is converted to this very active form, and it goes to the same receptors in the body that just regular testosterone does, and that's the direct pathway. So testosterone that goes and attaches to the androgen receptors in the body and has its effect. At high doses of testosterone, so if people overuse huge amounts of testosterone, it can go through the aromatization process and become estrogen, and actually can have some bad effects in terms, counterproductive effects in terms of masculinization. So we'll talk about that, but that's essentially the cascade. There's testosterone receptors throughout the body. So that's all I want to get across here. We'll talk about the specific changes in a moment, but really this is a hormone that all people need to preserve vitality, energy, libido, and it has effects that are far-reaching beyond physical changes and emotional changes.
So very quickly, so two questions. So the first one, and this may be premature, and if so, please let us know. But so if somebody were to come off HRT at any time, would they need to seek out a letter from a therapist to reinitiate that? And I think the answer is no, but
not if it's the informed consent process.
Okay. But if the provider follows the traditional WPATH guideline, then they may need to get a new letter.
I don't know why they would. If they've been on hormone therapy and they know the risks and benefits, I don't see why that would be a barrier, but it really is clinic specific. So for instance, the local clinic in Allentown, the Allentown Women's Center, I don't know what their protocol would be in that situation.
Yeah, I think that, so my limited experience on the transmasculine side, but generally is that, if you need to come off for some reason, unless there was like this, tremendous gap in years, 5 years or something, they might want you to, get a new letter. But I don't think that, for example, if you wanted to have a child or something like that, I don't think there's going to be necessarily an issue there.
Agreed.
Question. So we may be getting ahead here, and if we are, that's okay to say so, Leslie. So research around trans men who've given birth and have high levels of testosterone as weight gain occurs during pregnancy. Has that affected change or conversion with fat versus muscle?
So that I'm trying to understand that question. So after pregnancy, high testosterone levels in terms of body fat conversion, is that the question?
So is there any research around trans men who've given birth and have high levels of testosterone as weight gain occurs during pregnancy that has affected overall change or conversion with fat versus muscle?
Okay, well, that's a tough question. So I assume what we're discussing here is endogenous testosterone, because people should stop testosterone if they get pregnant, any exogenous testosterone, because it can be very damaging to a developing fetus. Developing fetuses don't get high exposure to androgens. So if you have it in your body, you could actually cause a deforming of the fetus. So if you have endogenous testosterone, that's usually a problem like polycystic ovarian syndrome or congenital adrenal hyperplasia. And in those situations, I know I have to look at each of those conditions separately. And there certainly is a tendency for weight gain with high testosterone levels in pregnancy for those conditions. And the way to overcome that is really by being very diligent with your diet. Unfortunately, it's very difficult, and following metabolic parameters very closely, such as your fasting blood sugar. But I think it's often a problem getting pregnant, and it's often a problem maintaining a healthy metabolic profile while pregnant for people that have a history of polycystic ovarian syndrome. For congenital adrenal hyperplasia, that's a different matter because it can be managed in various ways with other hormone therapies. So that's more of a specific condition that needs to be followed by an endocrinologist anyway, so I won't dwell on that. Does that Does that help?
Yeah, so I think that, the bottom line is you need, if you have that issue, you need to be working very closely with probably your OB and maybe an endocrinologist to make sure that
Yes.
we're managing things. Okay, great.
Probably a high-risk pregnancy.
We're going to have a couple more questions, but I think we'll get through your next section here before we ask these questions, I think so.
Okay. So I'm going to take some time to talk about different testosterone formulations, which I'm sure a lot of you have a lot of knowledge about. The common formulations that are used, injectable, so cypionate, enanthate, propionate was an old one, different injectable, either subcutaneous or intramuscular injectable testosterones. The difference between them is how they're suspended in various oils. Topical creams, gels, so androgel is the most common compounded testosterone creams that you can get in a compounding pharmacy are sometimes used. Less often, an axillary deodorant called Axiron. It's pretty hard to get. I've never prescribed it before. Patches, seldom used in my practice because of some of the side effects of them on the skin, but available for people that have issues with the other formulations. Less common, usually that means more expensive therapies. So pellet therapy, I'm starting to use this more in my practice. Previously, this was really something used by alternative medicine providers. So the quality and the consistency in the pelleted therapy that we use has not been tested as effectively or as aggressively as the other FDA approved formulations. But for chronic testosterone therapy, I think it's a really good option to try. I'm going to talk about that more in detail. Inhaled spray, Natesto, that's a new testosterone that was released about 6 years ago, I think. Doesn't suppress monthly cycles is the problem. So that could actually not be a problem though, if you're trying to, actively keep your monthly cycles going for egg donation or something from a fertility standpoint. Not really used so much in the trans and non-binary world right now. Then Striant, buccal, little tabs, also really expensive, but we're really excited about this formulation because it is an oral formulation of testosterone that just came out a few years ago, and it doesn't have any of the problems previously seen in oral testosterone, which was liver toxicity, which is why it was taken off decades ago off the US market. So injectable testosterone, really, cypionate's the most widely used. It's in cottonseed oil. Enanthate is a little more expensive. I use it as an alternative if you have an allergy to the type of oil that's in the cypionate. It's pretty obvious if you do have an allergy, you keep having injection site reactions with every injection, although it's not always an allergy if that happens, and I'm going to talk about that. More and more, we're using subcutaneous injections rather than intramuscular injections, and that's a very exciting new way of dosing that we've discovered in trans people. The safety data between the two routes of administration is essentially the same. And subcutaneous injections are a heck of a lot easier and less scary to do than an intramuscular injection. We use smaller needles, and you have more of an area, surface area on the body that you can inject into. So this is how I prefer to teach patients. We administer testosterone usually every week. I'll explain why, but there's options to spread it out more if you have, for instance, a fear of needles, or you are having an injection site reaction and you don't want to inject every week. There's options to play with that. The dose is variable depending on where you start. You're starting in your transition. The first dose will be different than your maintenance dose down the line, and it varies between individuals. Oh, there's this cool auto injector, Zyosted, that I have a couple patients on, just came out of not too long ago, and it can, if you have insurance that has really good pharmacy coverage, it's an option. It's a subcutaneous auto injector.
So we have a question specifically around sub-Q versus intramuscular. So any differences, preferences, or is it just a what the individual patient can tolerate.
I like sub-Q. I really do. I think a lot of us are changing to that because it's just less scary. So this slide is showing intramuscular injections. The needles are larger, so we use 19 gauge to 23, whereas in sub-Q we would use more of 24 to 26 gauge. Some people even use insulin needles. Testosterone's viscous. The oil is viscous, so it can be hard to get the testosterone through those smaller gauge needles, but really you're just limited on what you can handle in terms of how long you have the patience to push the testosterone in. The longer you have the needle under your skin, though, the more trauma you can cause by moving the needle around. So we want to find a good balance, but we want you to have a needle that you're not scared of using, so that you can inject yourself ideally. So sub-Q is more and more what we're introducing. I think I can speak for a lot of clinics that is what our preferred first modality is. But historically, in the cis population, it's always been intramuscular injections. And in feminizing hormone therapy, in large part, estrogen is still just an intramuscular injection. Hopefully that will also change as we get safety data back. But yeah, we're all very excited.
Not for this girl. This girl's doing sub-Q.
Really? Oh, interesting. Well, the safety data is not out yet. So yeah. The risk is necrosis under the skin, really, and a lot of irritation from the oils that the hormones in. Yeah. So I put some of the common needle lengths we use for intramuscular injections. You want to clean off the site with an alcohol pad and then go in at a 90-degree angle. This is after filling with a blunt 18 gauge needle, actually drawing up the testosterone with a blunt draw needle. And the purpose of that is to keep the injection needle as sharp as possible. So then you put on your injection needle after you've pulled up your dosage, and then you inject at a 90-degree angle into one of the sites that we commonly educate people on. And that's the outer upper part of the buttock and the thigh, we say lateral, but the outside part of the thigh. So looking at this kind of the midline. And so the outer 1/3 of the thigh is what we usually teach people. And the reason for this is that there's a lot of really important vasculature and nerves going through the groin area and coming out of the buttocks in these lower areas. So, I mean, it looks a little scary at first, but there's a lot of safety room here. If you get this roughly right, you're going to be fine. Sub-Q, on the other hand, one of the reasons we like it more, so you use still a draw needle. We still want to keep that needle nice and sharp. When you use your injection needle to dial up your dosage, so when you're pulling up your testosterone with your injection needle, you've punctured in that rubber vial with it, and you've blunted the needle. So what we want you to do is use a draw needle so that you keep the injection needle nice and sharp. So you want to switch those out once you have pulled up the testosterone. For sub-Q, it's these smaller needles. We use a smaller length, and we have a lot of different options about where we can do your injections. Really, anywhere that you can pinch up fat is where you can go. I don't ever tell people to go into their arms for hormone injections, but the thigh, around the umbilicus or around the belly button, you can go in the buttocks. You can go at a 45-degree angle. You don't go as deep as with an intramuscular injection, and hopefully it's not as scary to try for the first time. Are there questions about that on the?
Well, so yeah, so let me back up here. So we have some questions on testing, but I think that we'll hit those later.
Yeah.
So here's a question. Why are single-use vials different than larger reusable vials for tea? I feel like I'm throwing away large amounts of tea due to my vials being single dose.
Yeah, yeah. I have a lot of personal opinions about that in terms of the waste. It is unnecessary. So a lot of insurance companies want us to prescribe just single-use vials. They won't cover for the 10 cc vial. There's rules about throwing out a 10 cc vial. So it's either 1 cc or 10 cc's. I like to prescribe the 10 cc's so you don't have to go to the pharmacy all the time every month to go get a whole new prescription, but a lot of insurances decline that. The problem is that you're not supposed to use the same vial for more than a month and you have to throw it out. So people on lower dosages of testosterone end up throwing out a lot of their either single-use vials or multi-use 10 cc vials. That's just the way that insurance wants to cover it, and I don't necessarily agree with it.
Right. And from the same individual, so why do all T prescription vial manufacturers say IM when they're approved for sub-Q?
It just hasn't caught up yet. All of our prescriptions say that. It's very annoying. It's really difficult to communicate to nursing sometimes too. And it's confusing to the patient. Yeah, I agree. It's frustrating. It's written into the name of the testosterone. We cannot change it.
Okay.
Yeah.
So, and you might be coming to this, so to say so, but so have you ever worked with someone who has had to have an accommodation for their HRT shots or creams because of sensory processing concerns? So, concerns around, being, sensitive or high level of sensitivity to
Yes.
to getting injections.
Oh, yes, absolutely. Yeah, there are a lot of reasons to be on a transdermal cream or gel, and that is one of them. Is fear around needles. So I'll actually talk about that in a second.
Yeah, and this person originally asked about, are there any surgical options? So I'm guessing they might be thinking about like an implant.
Yeah. So you mean for hormone therapy? Yes, we're going to talk about pellet therapy in a few minutes.
Great.
I want to show you just a few things with the pharmacokinetics of testosterone because I think it can be illuminating. So when you start testosterone, you have your own production of testosterone. You have a baseline testosterone level, and every week on injectable testosterone, every injection, ideally for the first 4 injections you do, you're building up a serum level to its what's called steady state. Okay, I don't know why this arrow is here. This arrow is not supposed to be here. Oops. Come on. Sorry. Okay, what I was trying to show here is an injection cycle. So a lot of providers, me included, will say, we want you to get labs in the middle of your injection cycle. Your injection cycle is injection to injection. So this is time in weeks. So this person is getting injections once a week. They've had a buildup from their baseline to what's called their steady state. This is what their testosterone levels look like after an injection. So you have a peak. Oh, that's why I have the arrow there. You have the peak, which is right after the injection. You have the peak serum level of testosterone, which declines down throughout the injection week down to what's called its trough level. And that's right before your next injection. So we like to get labs right here. Sometimes we get labs at the trough level if you're feeling really crummy right before your next injection, and we want to see if you're getting below the therapeutic threshold, which is what this dotted line shows. So we're aiming for most of these labs, also these serum levels, I should say, to be between these 2 dotted lines. And this is an arbitrary range here, but that's the general idea. This ideally is the cis male range. I hope that that's helpful. So this is, again, the injection cycle. And so we're measuring from peak to peak. So mid-cycle labs are best. So for a weekly dosage, you want to get your labs 3 or 4 days after your last injection. And you need to have at least 4 injections to get to that steady state where your levels are going to be maximized on the dose you're on. And then again, sometimes we draw trough labs, but that should be specified by your provider, and you should let your provider know when you did your last injection so that they can interpret those labs appropriately. I want to talk just quickly about injection site reactions because it's really a common problem. It can happen because your needle is dull, you haven't changed it out from the draw needle. The alcohol hasn't dried, so it's causing some stinging when you do the injection. If your testosterone's cold, you might want to warm it up. Cold testosterone actually is painful to inject. Things you can do to prevent this from happening, really this is the pain component of it, to ice the area before you do your injection. and ice it afterwards and use NSAIDs if you need to, as long as you're able to take those medications. A lot of complaints I get are about the subcutaneous nodules that can occur. It's really it's a reaction of the body to the oils that the testosterone is suspended in. It can occur, these nodules, 1 to 7 days after the injection. They can last up to your next injection, which is the reason you want to make sure you're not injecting in the same place over and over again. You want to move the injection site to those other areas we specified earlier. A lot of times it's because people are traumatizing the subcutaneous tissue and moving things around with the needle injected. So try to keep that nice and still. Sometimes it means that you need to change the type of testosterone you're injecting. So a different oil suspension. So if it keeps happening, then that's really the best option, is to try a different preparation. Don't use the same needle. I hope I don't need to say that. Please don't reuse needles. Things to prevent these nodules from occurring. So massaging the area aggressively after you do your injection. You want to make sure that you're not bleeding or have any kind of opening there. But with a clean hands, try to massage the nodule area, use NSAIDs, rotate the injection site, and then make sure you tell somebody if it looks like you have an infection there, if you have any kind of pus-like discharge. Other issues with injections, and I'm sure some people have really encountered some of this. So bleeding. Sometimes you can get bleeding if you hit a capillary. Usually it's not a big deal, but if you're staying around those landmarks that I specified earlier, it's really not going to be a large vessel. Everybody has different anatomy in terms of small capillaries and nerves also. So there's a chance you're going to hit a small vessel that will just seal right back up when you withdraw the needle, but you might have some bleeding, especially if you're on some type of blood thinner, like aspirin or ibuprofen, or some of the other more aggressive blood thinners. One thing you can do is aspirate before injecting, meaning that once you stick the needle into the injection site under the skin, in the sub-Q or in the intramuscular area, you pull back on the plunger. And if there's blood that pulls into the syringe that has the testosterone in it, that means that that's the capillary you've hit, and you wanna move the area and re-inject. Z-tracking is a way to stop bleeding. It means basically that you pull the skin to the side and then inject. So you pull the skin where you're going to do the injection to the side and then do your injection in, and then release the skin, and it basically it seals the track so that you don't have bleeding and you don't have as much leakage. Some people have leakage at the site because some of these needles are rather large that they're using. Muscle spasm, same problem. So some subcutaneous, the lateral cutaneous nerve of the thigh, for instance, you can hit that, the small nerves coming off of that, and it can cause your muscles to spasm. It's really unpleasant. It's rare, but it's good to memorize if this happens to you where that happened, because if you go to the same place, it's going to happen again. So transdermal testosterone, which one of the questions was pertaining to, we use this a lot in non-binary people and people that are initiating testosterone with a goal of binary male transition. It's for people that are afraid of needles. It's for people that just want a more stable serum level of testosterone, and I'll show you that. You get to the same testosterone levels on the gel. There's a misconception that you won't get the same therapeutic effect on gel, but that's not true. You don't get the big oomph of testosterone in your bloodstream when you first do your injection. So that doesn't happen. It takes longer to accumulate over the month with the cream or the gel, but you still, at the end of the day, we'll get to the same goal ranges with all the preparations that we use. So if you have a lot of emotional lability on a big dose of testosterone, it might be nice to be on a transdermal testosterone, and you won't have so many mood swings. So it has the same clinical effect. It'll have the same masculinizing effect. And these are, I've listed out some of the reasons that we use gel specifically, or the patch or the creams. Some people have injection site reactions. They have underlying site conditions where they really don't want to have anything that could cause emotional mood swings. bipolar disorder, schizophrenia, things like that. We really don't want to offset that with hormone therapy. So it's a safe way to transition in those situations.
And I do know, so 100 years ago, I did testosterone gel many decades ago, and it was, I needed to be careful for my partner, who is a cis woman, in terms of her potentially, picking it up on her skin, right? So that's something to be aware of. Yeah.
Yeah, I will get to that next slide. We'll talk a little bit more about that. I just wanted to say quickly that one issue with this is you might have a little delay in getting it because of the insurance authorization process. In the corner here, I've put up some of the general places you do the application of the testosterone gel. I also have shown some of the serum level. The purpose of this is this graph down in the lower right side is to show this stability that your blood levels are at on the gel, and it's a very nice stable line there. The gel comes in 1% or 1.62%. There's really no clinical difference. It's an insurance preference. Comes in packets or pumps. Some patients have preferences of one or the other, but it's really, again, an insurance type of preference. You apply it typically back of the arms, flank, abdomen. You want to wash your hands afterwards for exactly what Corinne said. You don't want to get into bed with anyone. You don't want to touch anybody to your application site because you could be dosing them with a masculinizing therapy. I also say don't touch pets without washing your hands. In terms of adrenal implications, potentially, it's unclear what type of impact that could have. You can shower after 8 hours, meaning you're not going to get any more absorption of the testosterone. So I have patients typically put the testosterone on in the morning, shower at night, but you can do it the other way around, and don't worry about washing it off after 8 hours. It's done doing its job. Some people have some sensitivity to the alcohol in the gels. It happens a lot, unfortunately, especially if you're applying it to your genitalia, which some people do to try to get more of a masculinizing bottom growth. So keep that in mind. In those cases, we use a compounding cream instead. And I've seen recently some problems with levels with heavy sweating in athletes. So beware that could be an issue. Jumping forward to patches, I really don't like patches because they fall off and they also can cause a lot of irritation, but they are an option. We use them a lot in the cis population. I don't know really why we use them much at all. But there's things to troubleshoot if you do have an allergy to these. And you can use hydrocortisone at this site and then apply it over that, try to help with some of the irritation that can occur with these adhesives. Pellets. So pellet therapy is, I think, becoming more and more popular, especially for people that have been on steady doses of testosterone for many years, and they're looking for a chronic maintenance type of therapy. So you get this placed, these testosterone pellets placed by a surgeon, and this is called a trocar. And it's just an outpatient procedure that can be done in the office, and pellets are placed. I typically will give a recommendation for how many pellets I want them to place, and then I follow levels afterwards. It can be a little bit of a trick trying to find the right amount of pellets, especially since this is a newer modality that we're using. And insurance coverage is kind of wishy-washy. I'm still experimenting with that with our urologists. So I'm excited, though. I think that this is a really good way to advance our care. So monitoring testosterone. We really do labs every 3 months. We do baseline labs and every 3 months for the first year. And then after that, it's really a chronic medication. So every 6 to 12 months, we might do testosterone levels and CBC. And after a dose change, of course, we're going to want to see, you have to wait at least 3 months to get a new level. Really for your hematocrit is what we're looking at. Depending on your other issues, your BMI, metabolic problems, we might be checking other things more consistently, especially with the first year of therapy, because we don't know how testosterone is going to work in your body and if it will impact some other problems that could arise. We don't follow free testosterone levels. In people that are using exogenous testosterone. So we're not going to be checking those levels because they don't really have a lot of meaning. And estrogen levels are checked only if there's something going on that with monthly cycles not going away. I'm going to talk about that if we have time. I actually don't know if we're going to have time to talk about that.
We're getting a little short, but I just want to. So a question here. So what if at any point should various medical tests like CBCs or DEXA scans be compared to that of a cis male? For example, this person's docs were debating if this person's DEXA scan results were normal because they were in the range for a cis woman, but not a cis man.
Well, the ranges for cis men and DEXA scans are really not all that clear, depending on the age that we're talking about. For a DEXA scan, assuming that we're following a T-score, I think I'd have to hear about the patient more specifically and the situation.
Yeah, and I think that's a really good point to make, right? Is that everybody's situation is often individual, right? And you need to have good conversation with your individual provider on many of these issues. It's hard to do a diagnosis via Zoom, right? So
right. I will say that in my practice, at least, we err on the side of caution. So whatever range would be most important in terms of missing a diagnosis is what I would use. And I think a lot of people would use that, especially in terms of things like anemia or polycythemia. So for hematocrit or for a CBC, I think you also asked about that. That's a really important one because it flags in a lot of trans men and people on testosterone. Female reference ranges, for whatever reason, stick around even if you change your gender marker on your medical record. And so if your hematocrit is bouncing up on your labs, is flagging, it's probably because the range has not changed. So make sure you look at that on your lab. And if your provider is giving you guff about it, just make sure that they are aware of that. We use the male reference ranges if you're on exogenous testosterone. So be aware of that. I have a slide on that. I don't think I'm going to get to that though. There's other labs that we follow male ranges on, like creatinine and alkaline phosphatase levels. In terms of cancer screening, it's really more nuanced than that, and I don't have time to really get into that.
Yep, great, thank you.
So the rest of my talk was really about the secondary effects of testosterone therapy. So, I think it's really important to go through the informed consent process, know all of the things that can happen on testosterone therapy and what really is irreversible. In my opinion, really, you can try anything as long as it's reversible and it's doing no harm. But what we really need to have a conversation about is things that are not reversible. So in the realm of testosterone, that's body and facial hair growth, which can start to occur after 3 to 6 months and is really genetic in its outcome. A deepened voice. This will not go back to where it was before starting testosterone, ever. So once you have it, you have it. Bottom growth to some degree. So we're talking about clitoral enlargement. There's a little bit of reversion to the shrinkage up of the tissue down below with testosterone cessation, but in large part that is a permanent change. And then scalp hair loss, something we really want to prevent, but if you lose it, you lose it. And so we really are aggressive about preventing that. Otherwise though, things like acne, body fat redistribution, and the loss of your monthly cycles, those really occur over the course of 3 to 6 months and evolve after that for the next 1 to 2 years. What do you think, Corinne? I have time to keep going?
Yeah, you have another like 5 and then we'll
finish
up with a few questions.
So acne is the first big problem that a lot of people experience on testosterone therapy. You've seen, I'm sure, bodybuilders that have been dealing with that. We want you to have a good skincare regimen. We want to avoid this. We don't want you self-conscious about yourself once you've finally started this amazing process, right? Make sure you're washing binders. That's where this can be really a problem. You can get acne in places you never had it before. Luckily, this is really a problem during the initial year of therapy and goes away in large part after that. So be patient. Thickening of the blood, that's called polycythemia. This is why we check your red blood cells every 3 months. If you have sleep apnea or disordered breathing, if you're smoking tobacco, or if you're living at a high elevation, you can have a predisposition to this problem. And the options are to reduce the dose, which most people don't want to do, change to a transdermal preparation, or some people donate blood. And we follow this hematocrit of 55 in our guidelines. After that, we start pushing for what's called therapeutic phlebotomy. We usually have to do that in an infusion clinic or a cancer center. It can be kind of a headache to get it all together. And sometimes people just go and get, a little bit, just get a blood donation every 3 months, and that takes care of it. Then we don't have to lower the testosterone level if your serum levels of testosterone are looking good. Weight gain. So testosterone mediated weight gain is not safe weight gain usually. It's around the organs in the body. It's called visceral fat, and this predisposes you to heart attacks. And that's in contrast to subcutaneous fat, which is really more of an estrogen mediated fat. And like the reason that a lot of people get cellulite that have estrogen on board, it's more of a subcutaneous fat. So the beer belly, unfortunately, is what a lot of people have to look forward to if they do gain weight on testosterone. And it is a type of fat that can put you at risk for heart attacks and diabetes. Testosterone is an anabolic steroid. You're going to gain fat, you're going to gain muscle, one of the two. The real importance here is to try to stay metabolically sound, to try to exercise and make healthy lifestyle choices. And I think it's a really good time to do that when you start these therapies, because you are coming into your own authentic self. And it's a very motivating and activating time to make these kinds of changes. So I really, really encourage my patients to start resistance training of large muscle groups. It's going to give you a beautiful masculinization appearance, and it's going to be affirming for you. Other side effects, your sleep apnea actually can get worse. You can have relaxation of your oropharynx, which is really weird. So sleep apnea can get worse. You can get moody with the peaks and troughs of the testosterone cycle. You can have an increased sex drive, which can annoy your partner. Infertility is a conversation in of itself, in trans men and non-binary trans masculine people. It's not a end game in terms of fertility on testosterone or if you stop testosterone later, but still the best thing is to try to do preservation before initiation.
So we actually have a question related to this. So
okay.
I'm going to interject right here. So question is, I have PCOS, so I have to take birth control to get my period. How would this affect me also taking testosterone? Would I have to stop taking birth control because I know that testosterone also stops your cycle?
Well, I don't, and there's not guidelines specifically for trans men with PCOS, but the testosterone therapy is essentially doing what the combined oral contraceptive is doing in terms of LH and FSH cessation. So unless a patient needs to be on birth control for protection against pregnancy, or if they're having bleeding every month, I don't usually have people on birth control. They don't usually need to stay on it. But if they do have issues with monthly bleeding, things that started before testosterone, then sometimes we do continue it. I like to use progesterone only therapies in that situation so that they're androgen types of progesterones. Some birth control, there's different types of progestins, and some of them are more androgen-like, and some are more estrogen-like in their effect. So something that you can discuss with your GYN or primary care provider.
And I want to clarify just because we use the acronym. So PCOS is polycystic ovary syndrome, right?
Right.
So,
yeah. And a lot of people have it a lot of trans guys, a lot of non-binary guys have PCOS when I see them. It's a common issue.
And just kind of another follow-up on this. So it says, the comment is, since most people on testosterone aren't getting monthly menstrual cycles, do we need to be concerned about endometrial hyperplasia with the use of T? And if so, how do we counteract it? And are hormonal IUDs okay for trans men?
Yeah, all really awesome questions. I touched on some of it later, and I don't think I'm going to get to it, so I'll just talk about it now. So in in antiquated thinking, it was recommended that trans men get hysterectomies because of endometrial hyperplasia, concerns around that. Now that we have done a lot of hysterectomies and looked at the pathology, we realized that the uterine lining, instead of getting big and thick and being at risk for a cancer, actually they shrink up and there's atrophy there. So there isn't an increased risk of cancer, endometrial cancer, uterine cancer, or really endometrial hyperplasia causing bleeding. Now, that being said, it does still happen. And some patients that I have, we do have to refer them to an OBGYN to try to get those monthly cycles to stop, because it's out of the realm of hormone therapy. It's out of what I can handle in terms of changing your hormone doses. So sometimes things like IUDs, so hormonal IUDs, which are progesterones and are androgen type progesterones, those are used. So Skyla, Mirena often used, but can be less than affirming to, have place. But then Depo-Provera, that can be a good option. And then progesterone containing birth control pills.
So maybe, as we start to finish up, and I don't want to, if you have things that you feel you need to hit on, but, just fertility. So more and more trans masculine folks are deciding to have children, whether that is through IVF or through surrogacy or through other means, and maybe that's worth just talking about for a moment or two.
Okay. Yeah, it's important to think about it before initiation. You should have a idea of, you should at least have thought about this, especially if you have a current partner, before visiting your provider to talk about hormone therapy, because you don't want to get called out on it while you're there and think about it for the first time. Being on testosterone therapy it's possible that it's going to cause issues with fertility long-term, but not in all people. So we extrapolate a lot from the PCOS population, which is a condition where you have baseline levels of elevated testosterone. And those patients have problems getting pregnant. So we extrapolate that and say, that fertility issue is going to be a problem here, because it's the same type of mechanism physiologically. That being said, it's certainly doable in a lot of people. And there are pregnancies that happen that are unexpected. Testosterone is not a good birth control method. And one of the problems with having period cessation, monthly cycle cessation, is sometimes you don't even realize that you're missing that. You actually are pregnant and you don't know till later on. So the best thing to consider to begin with is, do you want to have a biological children that you would give birth to from your own body? Or would you want to consider donation of a gamete or an egg to a partner or a surrogate? Because the means to get there are pretty different. More and more, if we're doing egg donation or egg cryopreservation, I've heard that a lot of trans guys on testosterone therapy can actually get that done and not have to stop their therapy at all. And that's really exciting. People that obviously that are trying to get pregnant, we do want to stop that testosterone therapy because of the implications on the fetus and the developing fetus. And unfortunately, and people that do want to have a pregnancy within their own body, we can't guarantee that the fertility will be preserved. So we do have to follow up with things like IVF or IUI, so artificial insemination and things like that. So a lot of things to really talk about. There is a great reproductive endocrinologist in the area called is RMA, Dr. Gway at RMA, PA, who works a lot with my patients. So if you need a referral, I can help you out with that, or you can self-refer too.
Good. All right. So I'm sorry if I cut you off there. So you have a couple other things that you feel you want to really get across the line here.
Well, yeah, I think that's a really good point, and I'm glad we got to it. More common in the bodybuilding world, weakening of tendons. There can actually be tendon rupture with people that get really fixated on heavy weightlifting. So beware of that. It's kind of a nasty side effect, but pretty rare. I don't see it in my population really, but it can happen. Elevated triglycerides, elevated blood pressure, those kind of metabolic issues. Luckily, we haven't seen a huge risk of heart attacks and stroke due to testosterone directly. Now, when testosterone causes weight gain and diabetes and high blood pressure and cholesterol issues, then it can cause an increased risk of heart attack or stroke. But for people that don't have those other conditions, there's not an increased risk. Whereas in cis men, there is unfortunately an increased risk without having those comorbid problems.
Great. Good.
So I guess we'll stop there and see if there's things that anyone wants to talk about specifically.
Yeah. So we'll wait a moment here and let people, if they have specific questions they want to ask, keeping in mind that it's hard to do a diagnosis from, via Zoom. But we'll let people take a moment to see if there are any other particular questions that they want to ask about masculinizing therapies. And, and I just want to say, and Leslie, this is something maybe we want to think about, right? Is, do we want to think about at some point doing another session if you're open to it,
Yeah.
and maybe we almost do that as a Q&A, right? Where, people can maybe send in questions ahead of time, and, that'll give you time to sort of look at them and kind of put something together on that. That might be an idea for us to sort of look at.
Yeah, I have a lot to talk about, like, for instance, approaches to, hair loss, for instance, more specifics about contraception. There are other things that we could definitely touch on.
Yeah, I gotta tell you, so the hair loss one, just because I have 3 trans mask guys on my board who are all significantly balding, and I know that it annoys them to no end, and I guess I wasn't aware that there were options to try to deal with that. So
the best is Rogaine.
Yeah.
Otherwise, you're talking about testosterone blockers. Now, some of the testosterone blockers you can use, and it's not going to have a huge effect at the lower doses, but usually they're bigger blockers that will cause a blocking of the masculinization effect.
Right.
And you could resume having monthly cycles, which is really not desirable in most cases. So have to jump on it really soon. The minute you see that you're losing hair, you got to jump on it with your provider and get on Rogaine, which is over the counter. So you actually don't have to go to your provider.
Yeah. So we just have one comment here, which is just to thank you so much, Dr. Colip, for coming on. And I just want to tell you, you were such an amazing ally, beyond the work that you do with our community, from a medical perspective, but just in general. And I personally can't thank you enough. So
thank you. It's a privilege. It's a privilege every day. And I'm so honored to hear about your journeys and stories. I mean, all of my patients that I hear about how they have come to my office is just very meaningful for me. So I love what I do, and I wish that everyone got to go to have a patient, not patient population, but have a profession in medicine where they get to be part of an amazing journey, because it's seldom.
It is. So with that, I'm going to say thank you, Leslie. You're wonderful. Thank you to everybody who came tonight. As a reminder, we will have this on our YouTube soon. So with that, I will say good night.
Good night. Bye.
Good night. Thank you. Bye-bye, everybody.